Imagine a patient comes into the emergency room with a shattered arm. Like
Wow.
the bone is just completely fractured.
Right.
But then a few weeks later, not only is that bone healed, but the body has essentially shapeshifted to erase the fracture entirely. It molds the bone back to its perfect original shape.
Yeah, it's incredible.
I mean, it sounds like Wolverine from the X-Men,
Hmm.
but this extreme, rapid regeneration is actually happening on, every playground in the world right now. So, welcome to today's deep dive, where we are looking at the literal superpowers hiding inside a child's skeleton.
It really is a remarkable biological process. We tend to look at children and just assume they're scaled down adults right down to their bones.
Yeah, just miniature versions of us.
Exactly. But a pediatric skeleton is technically classified as immature, which, sounds like a vulnerability. But in reality, that immaturity is the exact mechanism that allows for this accelerated healing.
And that is our mission today. We have a massive stack of sources in front of us, specifically comprehensive clinical pediatric nursing protocols, radiographic analyses, and diagnostic deep dives.
A lot of technical material.
So much. But we're going to decode exactly how a child's skeletal system works, how it breaks, and how it heals. The goal here is to give you, the listener, a masterclass in pediatric musculoskeletal health, so you can really understand the invisible biology at work inside the growing kids in your life.
So, to understand the injuries children get, we first have to sort of map out the unique geography of a growing bone.
Right, because it's not the same as ours.
Not at all. If you look at a long bone, like the femur in the thigh or the humerus in the arm, an adult's bone is highly calcified and rigid, but a child's bone is wildly different. It's highly cartilaginous.
Okay.
And if we look at the anatomy, you've got the epiphysis at the very end, the metaphysis, which is the wider part, and the diaphysis, the long shaft. But the most critical piece of real estate is a cartilaginous band near the ends of the bone called the physis.
Which is the medical term for the growth plate, right?
That's the one, yeah. The physis is entirely responsible for the bone's lengthening. But the true engine behind a child's regenerative superpower is something called the periosteum.
The periosteum.
Right. It's a sheath that wraps around the entire bone, supplying it with blood and nutrients. In adults, it's relatively thin, but in children, the periosteum is incredibly thick and highly active.
Ah,
Yeah, it's constantly pumping a massive continuous supply of blood directly into the bone to fuel that rapid growth.
when I was looking at the diagrams of this highly vascular cartilaginous bone, an analogy immediately came to mind.
Oh, yeah.
Yeah. Think of an adult bone, like a dry, brittle twig you find on the ground in the middle of winter.
Okay, I can picture that.
If you apply pressure to it, it just snaps cleanly in two. But a child's bone is like a young green tree branch in the spring. It's full of moisture, it's flexible. If you bend that green branch, it might splinter, it might warp, but it takes a tremendous amount of violent force to actually snap it completely in half.
That is a perfect way to describe it. That green branch flexibility is really the defining characteristic of pediatric orthopedics.
Wow.
Because of the high cartilage content and that thick periosteum, children's bones tend to bow and buckle under pressure rather than snap. However, and this is a big however, this extreme biological drive to rapidly heal and remodel is a double-edged sword.
Because, if a bone can heal incredibly fast, it can also heal wrong incredibly fast.
That is the ultimate danger. Misaligned bone fragments in a child can become fused and solid in a matter of weeks.
Weeks? That's terrifying.
Right. If a child suffers a fracture and treatment is delayed, or if the medical team doesn't set the bone perfectly, that hyperactive periosteum will still lock the bone into place.
It just does its job regardless.
Exactly. It heals solid in record time, but it locks into an abnormal shape, which can permanently alter the child's structural future.
So rapid healing is great for a standard playground fall, but it requires serious precision to manage. And, speaking of those playground falls, the way that green tree branch bends leads to very specific types of injuries that you simply do not see in adult emergency rooms.
Yeah, the prime example from the sources is the torus fracture, which is commonly called a buckle fracture.
A buckle fracture.
Right. This happens exclusively in children because of that soft cartilaginous structure. Instead of a clean break across the bone, a compressive force causes the bone to literally crumple in on itself.
So imagine a kid jumping off a swing, landing hard on their feet, and the force travels up the leg.
Yes, exactly that mechanism.
So the bone doesn't break in half. The outer edge of the bone just bulges or buckles outward under the compression, kind of like crushing a soda can straight down.
That's a great visual. And following your earlier analogy, we also see the green stick fracture. This is an incomplete mid-shaft break of the long bones. The bone snaps on the side, taking the tension, but on the other side, it merely bends. And the clinical data on how often these happen is staggering. Boys have a 42% chance of experiencing a fracture during childhood.
42%.
Yes, and girls have a 27% chance.
Well, if you've ever watched a kid running full speed on concrete, this next statistic won't surprise you at all. A full 50% of those pediatric fractures happen in the distal radius,
Yep.
the wrist.
Yep.
Because your immediate biological instinct when you trip is to throw your hands out to catch the pavement.
Orthopedics actually has a very specific acronym for that mechanism of injury. It's called a FOOSH, F-O-O-S-H, fall on outstretched hand.
Fuchsia, I love that.
It's highly descriptive. That compressive force from a FOOSH travels straight up the arm. It is the leading cause of those distal radius buckle fractures. But if the force is strong enough, it travels all the way up to the elbow, causing lateral condylar elbow fractures.
Oh, those are the bad ones, right?
Right, because those often require surgical pinning since they run directly through that crucial physis, the growth plate.
Okay, this actually brings up a major mechanical question I had while reading. If a child's bones are so flexible and cartilaginous, why do the bones take the damage at all?
What do you mean?
Like if an adult trips and twists an ankle, the bone usually holds strong and the ligament tears. We call it a sprain. Why aren't kids just spraining their wrists and ankles left and right?
Oh, that's a fascinating detail. The physics of a pediatric joint are actually reversed. In an immature skeleton, the ligaments and tendons are actually stronger than the bone itself.
Wait, really? So the bone is literally the path of least resistance?
Yes. When a violent twisting or pulling force is applied to a child's joint, those thick, elastic ligaments refuse to yield. They hold incredibly tight.
Wow.
And because the bone is soft and cartilaginous, the bone gives way before the ligament tears. The ligament will literally pull a chunk of bone away with it.
Which perfectly explains the classic baseball pitcher elbow injuries in Little League. The repetitive throwing motion causes the strong ligaments to pull so hard on the soft bone that it causes a fracture.
Exactly.
Or, if you look at toddlers, you see this with the infamous nursemaid's elbow.
Right, nursemaid's elbow. That's a radial head subluxation, basically a partial dislocation. It happens when a toddler's arm is pulled suddenly.
Like swinging them by the arms.
Yes, or if you grab a child's hand to stop them from running into traffic. The strong ligaments hold, but the radius bone slips partially out of the developing elbow joint.
Before we move off common injuries, I definitely want to highlight the clavicle or collarbone. The sources note it is the most common birth injury, simply due to the tight mechanical squeeze of delivery.
Right, it's very common.
But what's fascinating is how invisible it can be. An infant can't tell you their collarbone is broken. Often, parents or pediatricians don't even realize there was a fracture until a hard, visible bump suddenly appears on the baby's chest a week or two later.
And that bump is the physical evidence of the periosteum doing its job. The moment the bone fractures during birth, that vascular sheath starts rapidly throwing down new bone cells to bridge the gap.
So it's just building a bridge.
Exactly. That massive callus formation is the body hyperhealing.
So a toddler takes a tumble, their green stick bone bends, and their periosteum throws down a callus to heal it.
Right.
That's the normal, everyday side of pediatric orthopedics.
Right.
But the clinical protocols we're looking at also dive into the dark side of these injuries. What happens when a fracture or a limp isn't just a clumsy moment, but a glaring red flag for something far more dangerous?
Yeah, this is where medical professionals have to shift from orthopedics to essentially detective work. Take toddler fractures, for instance.
Okay.
A child under 2 who is just learning to walk might present in the ER simply refusing to bear weight on one leg. Often it's just a minor, non-displaced fracture from an awkward twist while falling. But the shape of the fracture tells a story.
And the major caveat in the protocols here is the spiral fracture. If an X-ray shows a spiral fracture in the femur or the tibia of an infant or very young toddler, it triggers an immediate abuse protocol.
Because the physics simply don't align with a standard fall. A spiral fracture means the bone was subjected to a severe rotational twisting force.
It's like a ringing motion.
Yes, a non-ambulatory infant, or a tiny toddler, simply does not possess the body weight or the momentum to generate that kind of extreme twisting force on their own limb. Medical staff are heavily trained to recognize that mechanical impossibility and intervene to rule out physical abuse.
Right. The physics just don't add up.
Exactly.
But, the intense vigilance doesn't just stop at external trauma.
Yeah.
Some of the most severe emergencies happen internally, where the body's own inflammatory response threatens the child's limb. The sources heavily emphasize the supracondylar elbow fracture.
Yes, a break just above the elbow joint. That specific location is a major bottleneck for the arm's vascular system.
Right.
When that bone breaks, the massive swelling inside the arm can actually pinch off the major blood vessels and nerves traveling down to the hand. It creates a localized pressure cooker, known as compartment syndrome.
Which is terrifying.
It is. This is why you'll see nurses obsessively performing the 5 Ps of neurovascular checks.
The 5 Ps, that's pain, pulse, pallor, paresthesia, and paralysis.
Correct.
So you're checking the baseline pain, you're feeling for a pulse at the wrist. Pallor meaning is the hand losing its pink color and turning pale or blue.
Right.
Paresthesia is the child feeling that pins and needles, tingling numbness, and paralysis. Can they still wiggle their fingers?
If a child loses that wrist pulse or their hand turns pale, it means the blood flow has stopped entirely. That fracture must be physically manipulated and realigned immediately to unpinch the artery, or the tissue in the lower arm will begin to die.
See, that is a highly visible, high-stakes trauma. But what genuinely shocked me in the research were the non-trauma emergencies, specifically septic arthritis and osteomyelitis. This is a severe destructive infection of the joint or the bone itself, most commonly caused by a bacteria called Staphylococcus aureus.
An internal bone infection in a growing child is an absolute Tier 1 orthopedic emergency. If Staphylococcus aureus takes hold in a joint, the inflammatory enzymes will literally dissolve the cartilage and permanently destroy the growth plate.
But here is where I really struggle with the clinical presentation.
Yeah, so?
Well, if a bone infection is this life-altering, tissue-destroying emergency, how can the symptoms be so subtle? The sources say that an infant with a severe bone infection in their hip might just be like a little irritable.
Yeah, they might just refuse a bottle.
Right, or run a very mild fever. Their white blood cell count might even come back totally normal. How is a parent or a doctor supposed to catch a subtle fever before the hip joint is destroyed?
It requires deep physiological observation. You can't ask a 6-month-old where it hurts.
No, obviously not.
But you can observe how they alter their body mechanics to deal with the internal pressure. An infected hip joint capsule fills with pus and fluid. That creates agonizing pressure. To relieve that pressure, the infant will naturally externally rotate the leg, turning the thigh outward, because that specific physical angle creates slightly more volume inside the joint space.
Oh, wow. So the clue isn't on a blood test. It's the fact that they're holding one leg at a strange outward angle.
Yes. You might also notice an asymmetrical skin fold on the thigh because of deep, subtle swelling. Or you'll notice they don't cry when you touch the leg, but they scream specifically when you attempt to move the joint through its range of motion, like when you pull the legs up to change a doper.
And then the treatment has to be fast.
Very aggressive. Emergency surgical drainage to wash the bacteria out of the joint, followed by weeks of systemic IV antibiotics.
Man. So we've covered sudden traumas and hidden infections. But the final third of our deep dive looks at conditions that essentially hijack a child's entire developmental timeline. These are the chronic, congenital, and inflammatory conditions that require immense long-term intervention.
Yes, the long-term management.
And the logistics of some of these treatments are just astonishing. Let's start with the spica cast.
The spica cast is utilized for severe toddler femur fractures or congenital hip dysplasia. It is a rigid fiberglass shell that starts at the child's chest, wraps entirely around their abdomen, and extends down one or both legs, locking the hips into a fixed spread eagle position.
I mean, it is essentially outfitting a toddler in a non-removable, full-body suit of armor for weeks on end. The logistics for the parents have to be monumental. You have to physically turn and reposition this heavy casted toddler every few hours.
And you're tucking diapers inside the edges of the cast.
Right. But the hidden danger, the clinical notes highlight, is actually gastrointestinal. You have to actively prevent the child from getting constipated.
Well, the mechanics of immobilization affect the entire body. When a child cannot move, their gastrointestinal tract slows down dramatically. Furthermore, their abdomen is enclosed in a rigid shell.
Right, there's no room to expand.
Exactly. If a child becomes severely bloated or constipated, the stomach tries to expand, but it hits the fiberglass wall. The pressure has nowhere to go, which restricts their breathing and causes severe pain.
Which is why the protocol involves avoiding dairy and cheese, pushing fluids, and constantly sliding 2 fingers inside the abdominal edge of the cast to ensure there is breathing room.
It is an extreme intervention, but it's required to hold those powerful hip muscles in place so the joint forms correctly.
And we see a different kind of extreme caution with osteogenesis imperfecta, commonly known as brittle bone disease. This is a genetic defect, but it's not actually a defect in the calcium of the bone. It's a defect in the collagen production.
Right. Collagen is the essential scaffolding of the human body. Think of a bone like a reinforced concrete pillar. The calcium is the hard concrete, but the collagen is the flexible steel rebar inside that gives it tensile strength.
Oh, that makes sense.
Without healthy collagen, the bone is just rigid, unyielding chalk. It shatters under the slightest pressure.
And the diagnostic signs of this are fascinating. Because collagen is used all over the body, these children often have blue sclera.
Yes.
The whites of their eyes have a distinct bluish tint because the collagen in the eye is so thin you can actually see the underlying veins.
It's very distinct.
But the nursing intervention that stands out most is the danger of standard vital signs. You have to use extreme caution even when just taking a blood pressure reading.
Because the mechanical compression of a standard blood pressure cuff inflating around the arm can generate enough localized force to snap a brittle humerus in half.
From a blood pressure cuff?
Yes. You have to rethink basic handling. Medical teams use gentle, wide surface area lifting techniques, and treatments rely heavily on medications like bisphosphonates.
And those help build the bone.
They work by slowing down the cells that naturally break down bone tissue, trying to increase the overall bone density.
Then there are the physical remodeling interventions, like the treatment for clubfoot. Clubfoot is a congenital condition where the foot is rigidly plantar flexed. For anyone trying to visualize that, imagine the foot is pointed sharply downward like a ballerina on her toes and turned inward.
Right.
The ligaments are so tight, the foot literally cannot be manually pushed flat.
The treatment there relies on a biological phenomenon called creep. Doctors use serial casting. They apply gentle, constant tension to the foot and cast it in place. By keeping that constant mechanical tension on the tight tendons, the cells are tricked into regenerating and growing new tissue.
Wow.
Week by week, the old cast is removed, the foot is stretched a millimeter further, and a new cast is applied. Over time, the ligaments permanently lengthen.
The body literally remodels itself under tension. But sometimes the body attacks itself, which brings us to juvenile idiopathic arthritis, or JIA. When you hear arthritis, you immediately think of joint wear and tear in the elderly.
Right, osteoarthritis.
But JIA can strike toddlers as young as 2 years old.
Because adult osteoarthritis is mechanical wear and tear. JIA is a systemic autoimmune condition. Multiple genetic factors trigger the child's immune system to relentlessly attack the lining of their own joints.
And it's systemic.
Highly systemic. It doesn't just cause localized knee pain. These toddlers can suffer from enlarged lymph nodes, an inflamed liver and spleen, and even dangerous inflammation in the iris of the eye.
The interventions range from warm compresses and swimming to maintain joint mobility, all the way up to heavy-hitting biological agents. Like drugs like Humira or Enbrel are used to artificially suppress the child's overactive immune system so it stops destroying the cartilage.
It's an aggressive treatment for an aggressive disease. And finally, we look at structural mechanics with scoliosis, which is an abnormal lateral curvature of the spine. The treatment pathway depends heavily on age and growth potential, differentiating between juvenile scoliosis in children under 10 and adolescent scoliosis over 9.
The goal with a mild curve is to use a rigid plastic brace to mechanically hold the spine straight while the child goes through their major growth spurts during puberty. But if that curve exceeds 45 degrees, bracing is no longer mechanically sufficient.
No, at a 45-degree angle, the curvature begins to compress the internal organs, restricting lung capacity.
That's dangerous.
Very. That requires major surgical correction, using metal rods and screws to manually pull the spine straight and fuse the vertebrae together.
We have covered a massive amount of ground today. From the extreme physics of a buccal fracture to the systemic immune response of JIA. But what ties all of these varied conditions together? Why undergo the immense logistical burden of a spica cast or prescribe immunosuppressants to a 2-year-old?
It all routes back to the very first concept we mapped out today, preserving the physis, the growth plate.
Right.
Because a child's skeleton is a dynamic, expanding structure, every single intervention, from serial casting to emergency surgical drainage, is designed to protect that cartilaginous band. The entire medical approach is about safeguarding the child's long-term potential to grow straight and strong.
A pediatric skeleton bends before it breaks. It remodels at breakneck speeds. But because it is so incredibly malleable, it requires intense vigilance to ensure that rapid healing doesn't lock a permanent deformity into place.
The rapid cellular regeneration is awe-inspiring, but it needs an architect. It needs medical oversight to guide the structure.
Which leaves me with a final provocative thought for you to mull over. If a child's immature skeleton possesses this accelerated ability to literally shapeshift and heal solid bone in mere weeks, what secrets might that thick, highly active periosteum hold for the future of adult medicine?
That's a great question.
Right. Could unlocking the cellular triggers of the pediatric growth plate one day allow adult bodies to heal from severe, shattering fractures just as effortlessly? Could we trick an adult bone into thinking it's young again? Just keep that in mind the next time you're at a park and you see a kid rocking a neon green cast on the monkey bars. They aren't just healing. They are demonstrating the absolute peak of human regenerative biology.